Yeah, good evening, everyone. Today we are starting a long series of webinars, and this is a new series which is involving various journals published by various institutions. And when Harsha told me about this idea and we discussed with Dr. Janakram sir, we thought why not we start with our mother institution, the Hub of Learning, Royal Pearl Hospital, Trichy. And thus we have started this first journal club presentation with one of my presentation from Royal Pearl Hospital, which is a modified endoscopic septoplasty, a novel technique. I am Dr. Udaya Chanukya, a student of Hwang Medical College, Kakinada, and an alumni of Royal Pearl Hospital, working as a consultant ENT surgeon in Sai Hospitals, Rajahmundry. We all know Trichy as a city of temples, but for us students, mainly the ENT fraternity, Trichy is not just a city of temple, and it is just because there is Royal Pearl Hospital, the temple of learning. Royal Pearl Hospital, without any doubt, is the temple of learning for all of us, and without any doubt. Coming to the overview of this presentation, we'll just pass through these following headings while we cross over this presentation. We'll discuss about the indications of septoplasty, why an endoscopic septoplasty has gained importance, and why endoscopic and rather than a conventional technique. Principles of Royal Pearl Hospital and our paper on septal correction go hand in hand. Other publications regarding endoscopic septoplasty, 5-minute video of our technique, and followed by question and answer session. Coming to the indications of septoplasty. Septoplasty has varied indications. The indications used to be atypical facial pain, continuous or recurrent episodes of nasal bleeding, nasal obstruction, a part of obstructive sleep apnea surgery, as an adjunct to FES, DCR, and skull-based procedures. And the most important indication, which is very important in connection with this technique, is reconstruction after skull-based procedures, because any skull-based procedure needs reconstruction, and the best thing for reconstruction is a vascularized pedicle flap, and the nearmost location is the nasal septum, and it has a robust flap which is known as a Haddad flap. And whenever you do a septal correction, we do a septal correction as an adjunct to a skull-based procedure, we should have a very robust flap without any puncture to it, without any hole to it, and probably more commonly called as a tear. So we have to do a septal correction in a way so that we can reduce the probability of a tear to the minimum possible, and thus succeed in doing a very good reconstruction. Thus, our novel technique of septoplasty is a very refined technique, and it actually gives us the confidence of giving a septal flap in a very robust manner. Why endoscopic? This is a question from ages. Why endoscopic rather than a conventional septoplasty? Because endoscopic septal correction gives a direct targeted route to the anatomic deformity and gives a better visualization of high deviations and the posterior nasal septal deformities, which can rarely be perceived by a conventional headlight. Magnification of the surgical field is achieved only by endoscopic method, and once there is a magnified view, we can actually have a better perception of detail and better refined surgery. The most important thing of septal correction surgery is the assessment of the deviation preoperatively. The assessment has following things. First, we have to see whether the anterior deviation is towards which side, because we always give the incision on the convex side. Next thing is presence of a spur or not. If there is a spur, what is the height of spur? That means whether it is more towards the maxillary crest or towards the mid-level of the nasal septum, because there is a change in the way we chisel out the maxillary crest, deciding on both of these. Next thing is knowing the nature of the spur. If more commonly it is a cartilaginous and a bony spur, because the cartilaginous spur anteriorly has a foundation or the support from the bony spur posteriorly. This assessment has to be done preoperatively so that you have to plan your surgery. Now, these are the principles we follow in Royal Pearl Hospital. We will discuss again everything in detail when we discuss the journal paper in the next part of the session. We always do all the cases under general anesthesia. We infiltrate the septum at the base of the septum and the floor of the nasal cavity. If this is a septum and this is the floor, we infiltrate at the junction of the septum anterior to the mucocutaneous junction. Why is it a single infiltration point, because this is a very strategically placed single infiltration point so that we can do hydrodissection. And at the same time, whenever we put the scope according to the 15 commandments given by Dr. Janakram, we put the scope at the 11 o'clock position of the ala, which is, this is the floor where we give infiltration, and the infiltration, the endoscope route will be quite opposite to it, below and above. So there is a very less or least chances of contamination or fogging of the scope at the entry point. Next thing, multiple infiltration points all over the septum is followed at many places. But whenever there are multiple infiltration points, every infiltration point is an nidus of contamination or fogging of the scope. If there are 5 infiltration points, all those 5 points will act as a source of contamination whenever you go through the nasal cavity from anterior to the posterior part. Next, elevation under visualization. This is done to prevent unwanted tears. Whenever we try to elevate beyond a part where we can see, we obviously end up causing a trauma to the cartilage or the mucopericondyal flap also. Next thing is septal window. The septal window is created by removing a part of the anterior cartilaginous septum. How it is done, we'll discuss when we discuss the paper. This is helpful in lodging our endoscope because the septal cartilage along with the flaps will be of 4 millimeter thickness. So once we remove a part of the cartilage, we can achieve a 4 millimeter scope inside the bilateral mucopericondyal flaps so that we can actually see a septum in the midline and flaps bilaterally. Next thing is never elevate the flap over the spurs, because whenever there is a spur, there will always be a furrow on the opposite side. The spur and the furrow, the pericondyal flap at these 2 points will be very, very, very delicate. So if we try to go between the mucopericondyal flap and the cartilage and try to elevate it, there is every other chance for us to cause a tear in the flap on the both of the sides. Next, we'll proceed for the video. Before proceeding into the video, we'll just see our Royal Pearl Hospital's paper. This is the paper we published. It was published in 2018. Before actually discussing this paper, we'll go why this paper was published. Dr. Janakram sir was very fond of endoscopic septoplasty right from his starting of the career. But having followed various other techniques, by following journals published all over the world, he found some lacunae and some contamination points during the surgery, like fogging, insufficient removal of the cartilage. And after following every other technique, he actually got into this technique of his own, and we tried this technique over 250 patients over a period of 5 years. He actually started this study in 2018 and it was done till 2013. And this is a paper published. Normally we send a paper for a journal committee and they send us the review comments. This is the mail we got in on 2nd June 2017, having some minor review comments. This was done 2 times. We sent them comments and they gave us the replies, and this was sent for 2 times, and then our article was published in 2018. This is just for an information purpose. Coming to a paper proper. This is our paper which was published. Coming to the abstract, we had 258 cases, and which has 178 males and 80 females over a period of 5 years. The results will be discussed at the end of this paper. Without much introduction, we'll actually jump into the surgery proper. We'll first discuss what we have written in this journal paper, and then we'll go to the video so that we'll have a better understanding of what we have actually written in this paper. Nasal endoscopy has to be done to assess the septal deviation and spurs, which was already dealt. Septal infiltration is carried out with the solution of 2% xylocaine and 1:1 lakh adrenaline. This can be changed to saline also. Of late, sir has changed his technique to saline, but this was published in 2018. After that, he changed this technique to saline infiltration. And infiltration is done at a single prick at the inferior most part of the septum, at the junction of the septum with the floor of the nasal cavity to the mucocutaneous junction. It is anterior to the mucocutaneous junction. The infiltration given at the same point on both of the sides. The incision is always given on the deviated side, always given on the deviated side. Why? Because one thing is you can have the support of the cartilage. Whenever you want to try to elevate, you will have the support of the cartilage. And when you do elevation on the concave side by giving elevation, you can actually, you have to elevate with a blind elevation. This is convexity, you can see and elevate. Whereas in a blind, in a convex incision, what you can, the where you elevate is always a blind area too, and you will not have any support. So you might end up having a break in the cartilage and enter the opposite side. Why the incision is placed anterior to the mucocutaneous junction? It is always placed anterior to the mucocutaneous junction because the flap at the starting of that mucoperichondrium is very sturdy. It is not a mucosal flap. It is having a cutaneous thing in it. So it is very healthy, and there is very less chance for a tear or giveaway at that point. Coming to the elevation, the mucoperichondrial flap is raised on the deviated side with a Freer's elevator strictly under vision. That too until the anterior deviation part. The flap is not to be raised beyond the deviated part because the part of the septum posterior to the deviation is not under direct vision. Remember the principles only under direct visualization. The caudal end of the septum is then placed, is then palpated, and an incision is given cartilage 1 centimeter behind the columella. This 1 centimeter incision is, this 1 centimeter of the cartilage is saved to prevent postoperative tip deformities and caudal retractions. The cartilage is sliced 3 to 4 millimeter anterior to the first incision. The first incision, if it is somewhere here, we will proceed 3 to 4 millimeters after the elevation of the septum on the bare cartilage. We slice it. We don't actually go horizontally. We slice and enter the mucoperichondrial flap on the opposite side. The signal of the sign that you have entered the opposite side mucoperichondrial flap is whenever you slice, initially there is a avascular field, and once you go to certain thickness, you can actually feel a giveaway so that you have gone to the opposite side. And second thing is you will have a slight line of blood. That is very important. That means you have entered the opposite side mucoperichondrium. And once the opposite side is entered, the mucoperichondrial flap at the opposite side is always the non-deviated side. We'll say opposite or non-deviated. Opposite side is then elevated with a Freer's elevator. Now a cut is given in the septal cartilage as high as possible. What we have now is we have two flaps and a cartilage, a bare cartilage, which is elevated with of both the sides flaps elevated in the middle. So we take a scissors and we give a cut as high as possible and as low as possible. Once we give a cut superiorly and inferiorly, we take a Ballinger swivel knife or a 15 size blade and we remove that part of the cartilage by joining the upper and lower cuts. And once we remove that part, this is known as the septal window. A cut given superiorly, inferiorly, and the removal from the posterior part will actually take a small piece of the anterior deviated cartilage out. This actually helps in creation of a space for our endoscope to lodge in there. And thus we have, coming to the pictures, see this is the deviated septum on the left side and the spur towards the left side. And the third figure is infiltration point at the junction. Fourth is the incision anterior to the mucocutaneous junction. Once the incision is given, we have to elevate it on the left side until there is a direct visualization. Once we do it, we slice the cartilage and we have entered the non-deviated side here. This elevation will be done anterior to posteriorly until you reach the bony cartilaginous and beyond that also. This is the cartilaginous incision, and this is how we create a septal window with a Ballinger swivel knife. Once we create a septal window like this, what we see will be seen like this. Both sides mucoperichondrial flap and a deviated cartilage in the middle. There is a small cartilaginous portion here, and below it is the maxillary crest. Figures, and this is a technique of removal of spur which we will better understand when we see the video. Once we have created the septal window, the flap and the non-deviated side is elevated till the bony cartilaginous junction, and proceeding further, After reaching the bony cartilaginous junction, the flap is elevated downwards towards the floor. The elevation is done from posterior to anterior direction. Once you reach the floor posteriorly, we will elevate from the posterior to anterior direction. And this makes the flap on the non-deviated side safe, because we have completely elevated it without any tear. That means it is safe. The freer cell vesicle is then placed at the bony cartilaginous junction, and the inferior strip of the cartilage is sliced off from a maxillary crust. Now we have a bilateral mucoperineal flaps, a cartilage which is removed anteriorly, a small part of the cartilage, and then it is attached posteriorly and inferiorly. What we'll do now is to remove the strip of the cartilage from the maxillary crest from the posterior to anterior direction. In this case, if we see keenly, the spur is at the middle height. It is not towards the floor, and thus we can be rest assured that we are not anywhere near the maxillary crest while we do that action. Because whenever the spur is more towards the maxillary crest, if we try to remove, obviously it will cause a pressure towards the septal spur, and there might be a tear at that point. Once the cartilage above the strip of the cartilage is gently swung out, in case of any spur, bony cartilaginous flap over the spur is never elevated directly. The cartilage or the bone above the spur is cut at multiple levels. Remember what we have discussed earlier principle, we have to release the cartilage of the bone before removing it. This release is done to have a stability at the skull base. The perpendicular plate of the ethmoid joins with the skull base, and whenever we want to remove it, we have to release it superiorly and then make it stable above and unstable below, so that we can remove it from below. The freer salvator is placed between the spur and the flap, and is gently pushed. Now we have a flap which is safe on the non-deviated side, and there are lots of space on that side. So we go between the spur and the flap on the deviated side, gently push the spur towards the non-deviated side where we actually have a good amount of space. Thus, the stress or the strain on the spur and the cartilage on the mucoperitoneal flap on the cartilage and the spur will be as less as possible. So, because we are pushing it towards the opposite side, we are pushing, not elevating. Elevation causes a force on this. We are trying to push. So, this will be left undisturbed. And the freer salvator is placed between the sternum, gently pushed to the non-deviated side and removed with the flexili forceps. In case of any deviation of the spur from the maxillary crest, in some cases the maxillary crest itself is very deviated, because we have discussed a spur from the inferior part of the nasal cavity. It is chiseled out. This chisel is always directed towards the crest of the maxilla. If this is the crest of the maxilla, and if this is the crest of maxilla, the chisel will always be directed towards it, and the direction of the chiseling will always be towards the non-deviated side. Again, the same concept, because we have space on the non-deviated spine. And the chisel is always directed towards maxillary crest and towards the non-deviated side. And once this thing is done, the flaps are repositioned, and a diagnostic nasal endoscopy is done to assess the patency of the nasal cavities. Nasal cavity packing is used commercial by doing with the commercially available sponge packs like Merosil, using a Thudican speculum or a Killian speculum. In order to prevent the reflection of the flap at the incision site, we always pack under visualization, because once we put a Merosil, there is every chance that the incision site, the flap might get reflected or something may happen. So we always pack under visualization. Just try to oppose the margins and we finish. There is no suturing in our technique. The immediate post-operative management includes intravenous antibiotics and analgesics. Nasal pack is removed on the second day after surgery, and patients are advised oral antibiotics, antihistaminics, analgesic, and decongest nasal drops with saline nasal wash for 1 week. The patient is advised saline nasal washing for a week and discharged on the second day after surgery and prescription of the oral antibiotics. We have done 258 cases in this manner, and nasal obstruction was the most common presenting complaint. The duration of the patient complaint varied from 4 months to 6 months. All patients were treated medically before surgery with topical steroid sprays and antihistaminics. Diagnostic nasal endoscopy was done for all patients preoperatively with diagnostic nasal preoperatively. Our study found no major complications intraoperatively and in the immediate postoperative period, like nasal bleeding and all. Minor complications like hemorrhage and hematoma were seen in 1 patient. Coming to the discussion, Septoplasty is a standard procedure in the practice of otolaryngology aimed at relieving nasal obstruction. The rationale behind devising an endoscopic technique from a conventional headlight is to improve the visibility and for achieving complete correction of the deviation with minimal injury to the surrounding structures, thus improving the surgical outcome. Endoscopy aids the surgeon to localize the deviation and spurs under direct visualization. Correction of the deviation under endoscopic visualization enables the surgeon to achieve complete correction. Endoscopic septoplasty has already been described by various other authors, but not much of emphasis was given on how to deal in areas like acute spurs and deviations, whereas mucopericondyal flap is very much vulnerable to tear during elevation. This technique of endoscopic septoplasty is different from that described in literature. Infiltration given at single point, avoiding multiple infiltration points, facilitates a clear field inside the nasal cavity. The incision placed in the skin makes it less vulnerable to tear. It is always given on the convex side, which is easier and giving stability. The flap is not elevated beyond the vision, thus possibility of a flap tear is much less. Creation of the septal window or a working window increases the exposure and creates room for instrumentation. It is also helpful in assessing the deviation of the posterior part of the septum. Once we remove the anterior cartilaginous deviation, we can actually perceive what is what and we have a better visualization. The removal of the spur by pushing it to the opposite side of the opposite flap avoids the tear on the side of the spur. All these steps in our technique make it a novel technique. The complications encountered are very minimal and the patient report excellent relief of symptoms post-operatively. The technique can be used with success in revision cases as well. Now we will proceed for the surgical. Okay, we will proceed to the surgical video and then we will go for the other publication, other journals which were published on endoscopic septal correction. This is a case of a deviation with a spur on the right side. If we cleanly see, this is just located above and in the middle part of the nasal septum, somewhere near the middle turbinate, at the height of the middle turbinate. We can discuss about this when we proceed into the video. This is the right side, and whenever there is a spur on the right side, like this acute spur, there is always a furrow on the left side of the nasal cavity. Remember what we have discussed? The flap at this point of the furrow and the spur on the right side, both are very, very vulnerable. Mucopericondyal flap here and mucopericondyal flap here. Both the locations, it is very, very vulnerable. Coming to the video, we have already finished infiltration at the junction of the septum and the floor of the nasal cavity anterior to the mucocutaneous junction, which is this place. That's why we can see blanching all over this area. This is the incision which is given anterior to the mucocutaneous junction. This is a mucocutaneous junction and it is given anteriorly. The initial part of the elevation will be a three-handed technique where the assistant puts a suction and the surgeon tries to, this is the assistant which has put, who has put the suction, and the surgeon is trying to get into the mucopericondyal plane with right hand, and the endoscope is held at the lemnocular portion of the nasal cavity with the left hand. Once we have entered this mucopericondyal flap, the assistant is asked to...
Udaya Chanukya,
yes, sir.
Small thing. Dr. Prakash Munka says the video is not visible. Harsha, can you rectify it?
No, sir, it is visible, sir. I think there's some issue with the internet connectivity. I'll try to sort it.
Okay, okay. Continue. Please continue.
Can I continue, sir?
Yeah, please continue.
Or should I restart it?
No, no, please continue.
Okay, sir, I'll continue. Okay, we'll just go briefly back. Once we enter the mucopericondyal flap, the surgeon's assistant is asked to tent the flap with the help of a suction. They tent the flap, and once the assistant tents the flap, the cartilage is sliced. If we see keenly, the cartilage is sliced, and the signal is there is a flow of blood. Once we have entered this plane, we use the Freer's elevator and we enter the plane on the non-deviated side or the left side. Once we have entered into the plane properly, we proceed for the elevation posteriorly, and once this is the bony cartilaginous junction here, and once we have crossed it, the elevation will be proceeded towards the floor of the nasal cavity. Once we go to the floor of the nasal cavity, the elevation is been from the posterior to anterior direction. This is the elevation on the deviated side, which is the right side. Remember the principle, never elevate beyond the visualization. So this is the end of the anterior deviation, and from there the cartilage is going in the other direction, so we cannot see what is beyond. That's why we'll stop at this point. At this point, the surgical septal working window will enter. Remember the cut as high as possible superiorly with the scissors, and cut below as possible inferiorly. This is a Ballinger swivel knife which is used to take the anterior cartilaginous deviation part. You can always use a 15 size blade also, and the deviated anterior part is removed. This is the picture after the septal window is created. Remember, we have the deviated cartilage in the middle, or the cartilage, bony cartilaginous thing, and flaps on either side. This is the non-deviated side, and the whole flap is elevated safely, and this is the deviated side which we should bother about. Once this is done, we actually we try to elevate it further posteriorly, and everywhere we elevate, we release, we remove, we visualize, we continue. We elevated, we cut, we further elevate. This is the place where we have encountered the spur. We come out, we assess, and again we release with the help of scissors, and we remove that part of the septal cartilage. This is one important step which we have discussed. Always push. See, once we remove this part, we are putting the Freer's elevator between the cartilage and the septal flap on the deviated side, and see the direction of the push. Direction is towards the non-deviated side. We are not trying to elevate, we are trying to push. And once we push, the part of the cartilaginous deviation is released, and this is also a partial success because the spur is still there. Now we go to the below, we go to the orthomaxillary crest. This is the cartilage which is lodged over the maxillary crest on the non-deviated side. Again, this is the thing where we said swing the cartilage from the maxillary crest. We released and we swung it out anteriorly below, and once we achieved it, what we have discussed earlier is the height of the spur, which is almost near the level of middle turbinate, which is quite above the maxillary crest, and that makes us see this is the maxillary crest below, and having assessed the height of the spur, we can actually work on the bony septum on the below the deviation. See, this is the deviation on the right side, this is the deviation on the spur on the right side, and we have this much space where we can work below the spur. And once we enter this plane, we follow the same process. Go below, elevate towards the floor, elevate towards the floor, elevate posteriorly. This helps in securing the flap above the spur and below the spur. This is the strip of the cartilage attached to the mucoperiocondylar flap, and this is the spur which is still attached, but the cartilaginous flap, mucoperiocondylar flap, is free above and below. Now we chisel it out. See, the chisel is directed towards the non-deviated side and directed on the maxillary crest. We chisel it out, and then the anterior maxillary crest, which has been supporting this inferior part of the cartilage, is already gone. Now the cartilage is without any support from below, from superiorly, and posteriorly it is attached, which we will work later, but it is already removed and made unstable from above and below. All we have is a mucoperiocondylar flap above and below, which is good, and a small cartilaginous spur which is attached all through it. Again, we follow the same thing, go between them and push gently. See, we are not elevating, we are pushing it towards the non-deviated side, because we have space there and we can elevate it towards the opposite side. Once we did it, this is the cartilaginous part. It will have a bony support posteriorly. See, this is the bony support which we were talking about. The anterior part of the cartilage is already, anterior spur of the cartilaginous spur is removed. That part is the bony spur, which is supporting the cartilaginous spur. Again, the same concept. Elevate above, elevate below. Below elevation is already done. Above we have elevated now. Again, release superiorly on the perpendicular plate of the ethmoid bone. Again, push towards the non-deviated side. Once we push to the non-deviated side, see how we have elevated it towards the opposite side, and thus we have removed the whole cartilaginous, both cartilaginous and bony spur superiorly and inferiorly. There is a small strip of the cartilage still remaining, and this is attached to the anterior most part of the maxillary crust. Now we have, the job is very easy. We have to just release it on the maxillary crust, which we will do with a knife. And now that it is free, we'll just go below between the two things and then gently push towards the opposite side. This has no support in any direction, so this is the most easiest part of the surgery. Once we have removed this inferior part, the whole thing is over. This is the non-deviated side and that is the deviated side. Whenever we remove an anterior cartilaginous window, if in this case the piece was a bit less so that we could not reposition it, and whenever we achieve a good amount of cartilaginous anterior deviated septum, we can actually position it back after this whole thing is done. This was the published paper of us, and now we'll proceed. Sorry, 1 minute. And now we will proceed with our discussion regarding the other journal papers. These are 3 journals which have been highly cited in almost all the research papers published regarding endoscopic septoplasty. And we will not read the whole paper. We'll just go to the surgical section of this paper, and where some parts of them are highlighted, which we think are the lacunae in this paper, leading to the evolution of Dr. Janakaram sir's technique. In this paper published by Hwang in 1999, the incision of the septoplasty is best made on the contralateral side of the maximal deviation. In this, we have concerns like incision on the non-deviated side, cartilaginous deviation is elevation without visualization, which is against our principle. And why it is harmful is because there is no support to your elevation, and you can actually break the septum and go to the opposite side. Elevation on the concave side is without the cartilaginous support, and elevation of contralateral side to the deviation is elevation without visualization. So this is the lacunae we have found in this paper. And a suction elevator, one more important thing which I forgot to discuss is usage of suction elevator. A suction elevator is never used in our technique, because why? Whenever there is a suction, there is a field of negative pressure all around the suction point. If your suction elevator is in this direction and the port is located here, the whole point around, the whole place around this area, around this point is having a negative pressure. So whenever there is a negative pressure, your surgical field will have blood, will have instruments, everything, a connective tissue, and where there is a negative pressure, things will get sucked in. So wherever there is a small drop of blood, it will try to go into that point, and it will obviously hamper your vision. It is like driving without the visor on a heavy rain. So you cannot see what you want to do. So a suction elevator is suggested to be used in this. So we are against using a suction elevator, and the reason is fogging. Then flap elevation is continued bilaterally until the complete extent of the septal deformity has been dissected. See dissection, and until the complete extent of the septal deformity has been dissected. This paper suggests the elevation till the whole flap. So it is against the concept of our principle, which is elevation beyond deformity is blind elevation and a strict no according to us. Next thing is in this paper, it has been said that a small orthopedic cutting punches, a small strong cutting punches can be used to remove the cartilaginous deviations. And again, it is a strict no. Why? Because whenever you try to hold something and punch it and remove, you are not actually holding the whole small thing. You are actually holding the whole septum, perpendicular bone, anterior cartilage, everything. So there is every chance that you may cause instability above, which is the skull base and a very important area. Better not to remove anything without visualization, and we need big pieces if you want to remove or reposition good parts, not nibbled ones. If you want to reposition a good amount of chunk of cartilage, it should be cut in a big piece, not with a small forceps. And whenever you want to punch and remove, you can cause instability to the superior part of the septum. Next thing is addressing septal spurs. This is something which is regularly done. Whenever there is a spur, a small incision is given on the spur and the flaps are elevated superiorly and inferiorly. Small chisel or a chisel is placed, and then it is hit, and this part of the spur proper actual spur is removed and the flaps are repositioned. This is also a no from our side, because whenever you are hitting, one thing is you will not have room. Second thing is you never know how thick is that. Third thing is you are obviously acting with whole force on the opposite septum, and you have already given incision on this spur. You have already given incision on this spur, and you are acting with full force on the opposite side of the flap. So whenever there is a small accident, the chisel osteotome will go to the opposite side through and through, causing a probability of a septal perforation to happen. So we are also against this step described in this. And this is Hwang, which was published in 1999. And then comes Friedman's paper in 2006. This is a very good paper, and there are very less things where we differ with this. One thing is the incision on the spur. If this is a spur, this paper also emphasizes on incision and removal of the spur by both a Cortell's elevator or a Freer's elevator or a powered instrumentation also. This is the flap incision which they have given, and this is how they elevated, and this is how they want us to take the cartilage and spur with the help of an osteotome or a powered instrument is also said to be used in this paper. This is a septoplasty burr, and this is another point where which we differ. The infiltration can be done from anterior to posterior or posterior to anterior at various points. We are against infiltration to the various points. The reason being, every point where you have infiltrated is a possible nidus for contamination or fogging of the scope. Here they have described the technique using powered instrumentation, a powered septoplasty burr. The instrument is positioned after elevation of the flaps with the burr facing the spur and subsequently shaved off until the opposite surface is reached with the rest of the septum intact. So when we reach the opposite side, one thing is there might be injury to the opposite side. Second thing is, whenever you use a burr or a powered instrument, it is obviously attached to a suction port. Suction port will be attached. So that's why they have already said themselves, in a narrow septal cavity, the suction from the microdebridator makes the procedure more challenging, because the vacuum created tends to attract and collapse the mucosal flaps around the instrument. The same thing is applied to a suction elevator also. So that's why we differ with these two things in this paper. And coming to the third, another paper which is highly cited in almost all endoscopic septoplasty articles is Chung, which was published in 2007. In this, they have recommended a Killian's incision, and we are giving an incision anterior to the mucocutaneous junction. And that's why beyond the mucocutaneous junction, the anterior, the reason being, if there is a anterior most deviation, high anterior deviation, you cannot correct with a Killian incision, because the anterior part of the cartilage will not be addressed at all. Next important thing in this paper which we want to discuss is, if you see in this picture, this is a double action punch, and they are punching this cartilage or bone out. This is a cartilage, and without going into the, I have gone through the text, and there is nowhere mentioned that the above part is released from the skull base. So this sort of punching action might cause instability to the skull base. See, this is removal without releasing the cartilage or bone above and below might cause instability at the skull base. Next thing, this paper also recommends isolated septal spurs to be removed in the same way the other two papers have said, and the same comments goes to this again. We are against isolated release of a septal spur. And these are the three papers which are commonly cited in almost all, and even we have cited these three papers, and we have cited these three papers here. Hwang, Chung, and that's all. This is the thing which I wanted to show apart from our paper published, and we have already seen the video. So without much ado, I'll say thank you and we'll proceed for the question answer session. And I thank my mentor teacher, Dr. Janakram, for bestowing me upon the knowledge which he has gained through many years of experience. And I thank Sriharsha and Bhargav because of their initiative through Sahasra ENT Foundation. Such a wonderful initiative to share knowledge during this lockdown period, and they have already they have progressed it to the next level by starting this journal club, because not every one of our busy practitioners, or when we go into regular practice, will not have much time to go through various journals and then decide on a technique. So whenever we have a journal club like this, we can see one technique, the pros and cons of various techniques being followed, and a proper refined technique in one institution. You can actually follow this, make your changes, make it, amend it according to your thing. If it is positive, you can publish. If it is negative, you can review yourself and then refund your surgery. And I hand over the session for the question answer session, and I welcome Dr. Janakram sir and Harsha to stay with me till the questions are ended. Thank you. Sir, please unmute.
Thank you, sir. Sir, Jankiram sir, I would like you to start.
Yeah, before the question answers are starting, I want to mention a few points here. First of all, I congratulate Dr. Udaya Chanukya for a fantastic presentation. It was mind-blowing. I generally don't say fantastic and all. I don't want to praise anybody. I am very critical in my analysis.
Thank you, sir.
First of all, I want to say that if I have a septal deviation,
Sir, please.
I will, no. Why should I flatter you? I will get it operated only by Udaya Chanukya, nobody else. This is for sure. I am very confidently telling, because I have seen him as a surgeon. And I generally don't praise everybody just like that. He is a fantastic surgeon, number one. Number two is, I have seen the whole world. I have seen this whole world operating on septal corrections. And I have very clearly understood that people have still not understood septal correction properly. This is my honest confession, because I doing tears on one side. Yesterday also I did a case, a huge septal perforation has been created because of the septal correction. So I think understanding, many people also postgraduates say, I have done basic surgeries. What are the basic surgeries you have done? I have done septal correction, I have done tonsil, and I have done master. These are the commonest answer which any postgraduate will say. And to me, I think if you have done the most difficult septal correction, endoscopic, I think that is the height of endoscopic sinus surgery. Even FES, or the endoscopic sinus surgery, is not difficult at all. But to do a difficult septum, and more importantly, to do a revision septum, and more importantly, yesterday I did a case where the surgeon had created such a big perforation, and still the deviation was extremely high. And Shilpi was watching. She said, "How did you do this, sir? Because it's almost impossible to operate on a second or third revision septum with a big perforation and to correct that septum." So if a person says, "Sir, basic surgery, septal correction," then I already understand that this guy has got no idea about septal correction. So that is one point. Second point, I want to tell you that from Royal Pearl Hospital, all our residents have presented more than 50 to 60 international journal papers. So I'm very proud to say that our hospital not only has got talent to operate, we produce people who have got talent to operate, but also we have published, in fact, our publication recently is in JAMA. JAMA is like a dream publication. It's a dream publication. It has already been cited, I think more than 100 or 150 times already citation has been done. It's in the index factor is, I think, 45 or 50. You please go and see what is the index factor of JAMA. And such publications come from Royal Pearl, and we are very proud that our residents are doing a fantastic job. Thank you, Dr. Uday. I am now ending my talk without much ado. We will throw the thing for a discussion and also question answer session. We have Dr. Prakash Munka sir here. He's a great person, and we would like to have his comments and also questions from other people. Over to you, Dr. Chanukya.
Yes, sir.
Dr. Prakash Munka sir's question was suction
Is
elevator.
he here? Unmute him and make him talk.
Yes.
Hello. Make Dr. Prakash Munka talk, please.
He's already unmuted, sir.
Is he there?
Yes,
I
yes.
can't see him.
I think his internet connection is little weak.
So there was some vibrating sound somewhere.
Audible.
Yeah, actually, I have some net problem today. I don't know.
Yes, sir. Good evening, sir.
So,
Good evening.
good
Dr.
evening. Yeah, Uday, you had an excellent.
I think it's a internet.
Sir's voice is having some
The
problems.
suction or the Freyr's elevator, because this habit of reviewing the article and
Munka sir, can you repeat your question again?
no, it is not a question. It is already replied by Dr. Janki in the chat box. I just asked. First of all, I congratulated Uday for an excellent presentation. Secondly, the Freyr's elevator or vis-a-vis the suction elevator, because nowadays we find many people using that suction elevator, which I never prefer, and so is Dr. Janki replied to me. So that is what I wanted to comment.
Yes, sir. Thank you.
Thank you for being there, Dr. Prakash ji. We have Agila Sami. I think Agila Sami, do you have any question? Dr. Agila?
Sir, good evening. Hello, sir.
Hello, Uday, can you hear me?
Hi, sir. Hi. Hi, sir. Please tell.
I watched the full presentation. It was really an excellent way.
Thank you.
Excellent.
Thank you, sir, for giving your very valuable time. Thank you.
There is a proverb in Tamil. Puliki parandadu pune aguma. That means that means who are trained by Janaki cannot be so small.
Thank you, sir. Thank you. Thank you for your time.
I really didn't think that your talk will be such a great thing. And in fact, I am watching so many webinars in this lockdown period, and your talk was such better than so many senior people's talk.
Thank you,
and
sir.
your voice, the way you modulate, all things you are inherited from Janiram. That's the biggest advantage.
Yes, sir.
Thank you.
There is the biggest advantage. Truth.
Yeah, I don't have much comments, but I do all endoscopic septoplasty. But I always put my incision on the left side, whether the deviation is on the left side or right side convexity. I always put the incision on the left side. That way I started, and I am a right-hander, so I am comfortable on the incision on the left side, whether it is concave or
have you faced any difficulty rising on the concavity, sir? Have you faced? Because you are a very experienced surgeon. So give us your inputs. Like what we have said is whether when we look on the concave side.
Yes, the point I was coming before that you asked the question.
Yes, sir.
So whenever the septal deviation is to the left, DSL, the septal deviation to the left, I always find it easier. So when the septum is deviated to the right side,
yes,
that is the concavity, I always find it difficult. But since I am used to it, I couldn't change it. But as you told, as Jani put it, if you are putting on the incision on the concave side, it will be easier. I agree.
Yes.
Totally agree.
Yes, sir. Various papers have
And with Chanukya,
I want to tell you one thing.
yes, sir.
So more than that, I want to tell you that there can be S-shaped deviations where you have both a concave and a convex side. So where do you choose the incision when you have both a convex and a concave deviation is also taught by me. That is, wherever you have the anterior part which is deviated, where is the anterior convex deviation? That is where we put. So
Yes,
even if you have a slightly mid
then we can address it.
convex deviation on the other side, we choose where the anterior convex deviation is, and there there's some noise. I don't know what some noise is there. We make the hello.
Actually, the noise was from Ahila Swami sir's background.
Oh,
I've muted.
Ahila is on 2 or 3 webinars. So, so what we do is we make the incision on the anterior convex side. This is very, very important.
Anterior
Because
convex.
only then you will not tear the side, the same side. Or else invariably, if you put it on the concave side, you are landing with the tear on the either convex or the concave
So
side.
I'll just
Uday, I want to add one point. Uday, Ahila Swami.
Yes, sir, please.
When you are telling about one point, I want to add. You are telling about pack removal and discharge the patients. You are telling 2 days after surgery, I remove the pack. Is it 2 days or the next day?
No. Next day.
Next day.
Okay. I want to tell you, when you are always referring up any event after surgery, always refer with post-operative day 1, post-operative day 2, like that. Don't tell 2 days, 1 day after surgery.
POD 1.
That will,
Yes, sir.
yes,
That will be
POD.
correct.
You always refer with
Post-operative
POD.
day 1.
Yes, that is the word. And one more thing, I always don't pack the nasal cavity after septoplasty. I put a quilting stitch round around, and I send the patient same day evening. So that's
Yes,
my
I want to tell you one point, Dr. Uday. See,
Yes,
there are some people who create tears. They voluntarily create tears
to prevent hematoma.
because they don't want the hematoma, so that they also don't pack also. So, but in our center, we always say no tear, because tomorrow if we want a Hadar flap, we always think like a skull base surgeon. We don't want a tear on any side of the septum. And this is a good practice for you to become a level 1 or level 2 skull base surgeon. So if you try to practice even in a deviated side, not to tear the septum, this is always the first step for you to become a good skull base surgeon. So this is a very important point, and don't try to do that. So whenever I see Stamberger or Kennedy, Professor Kennedy operating, they make the horizontal incision as given by then I always say you accepted defeat. You accepted defeat on the first instance, and then you don't show your class in your septal correction. And very important, you mentioned you make it on the skin, never in the mucocutaneous junction. I've seen even top stalwarts operating, when they actually retract it, they'll make a small, there will be automatically a very small tear along the inferior part. Along the inferior part, you can see that. Once I see the tear, I will get BP of 220. My BP will rise, I'll get my BP to 220. Oh my God, that's it, finished. That guy is gone. So these are all the important points you have to remember when you do septal correction.
Yes, sir. And I'll just sum it up what Sir said regarding S-shaped deviation. Whenever there is a S-shaped deviation, Sir just mentioned that you have always you have to give incision on the anterior convexity. Whenever you give an anterior convexity, and once you create that septal window, the posterior part of the S will become clear to you. So that's what Sir added, and I'm just repeating for all the participants. Once you have a control over the anterior part.
One point I wanted to ask your opinion.
Yes, Dr. Prakash ji, please.
Yeah, just one point about the incision on the concave or the convex side. Since we are going to raise the flap on either side, yes, concave is easier. But even if you go to the other side, since we are going through the cartilage, making a window and going that, elevation is really not very difficult. So I think, is it standard that you should follow the concave side?
Yes.
As in my practice, I can go either side and I don't mind.
So
So
the second part of the elevation after giving the cartilaginous incision is
yeah,
the same for both the techniques. When
exactly.
we do a convex incision or a concave incision, the second
Mhm.
part of the elevation on the opposite side of the mucoperitoneal plane is always the same. But giving the incision on the convex side will be helpful for us to elevate, because one thing is our incision is anterior to mucocutaneous junction. The elevation
Yeah,
anterior to the mucocutaneous junction is not as easier as you go on the mucosa, because if you infiltrate and give in the incision on the mucosa, you can just directly
mhm.
enter the mucoperitoneal plane without any hiccups. But the
Right.
incision being anterior to mucocutaneous junction, you need that extra effort to go into that plane, and you need to have some scaffold or support inferiorly. That is given by the convexity. If there is a convexity, you can put force and elevate. Whether if
Well,
there is a concavity, you just put force, but you will not have any support from below, and there is every chance that you can end up breaking the cartilage also. This is one thing where we have already made some research, because we tried doing that also. Initial parts of the residency, we used to do every other thing which we are not doing, and whenever we used to get this pearl of wisdom from Janakram sir, because we have seen and learned from him, and we have got trained under him. He always gives it on the convexity, and the only reason is you can have a support and you have to elevate a sturdy flap. These two are the
One
reasons
important
for the
point
convexity.
here, I want to add one
yeah,
point, Dr. Udaya. See, the convexity can be of two types. One is called the smooth convexity. It is like the smooth convexity. For a smooth convexity, a very mild smooth convexity, it doesn't matter in a big way whether
Yes,
you make it in the concave or convex side.
but there
But
are
if you have a L-shaped
also.
convexity, imagine you have a L-shaped convexity like this L-shaped convexity, then making incision on the concave side is a disaster. Disaster. You will invariably tear the convex side. So there is a disaster. So whether it is a smooth or a L-shaped convexity, the best is to give the incision on the convex side rather than to give an incision on the concave side. It's very
Yes.
important.
Sir, we have one question. Do you replace the septal window back after the end of the surgery? Yes. Yes. If it is a straight piece, we immediately replace at the end of the surgery. Can you please share other journals you referred, sir? Please put your mail ID here. I'll get it from Dr. Harsha and I can mail you them. And the next question is, how long you give antibiotics post-operative period? We give IV antibiotics as long as the intranasal pack exists. And once the intranasal pack is out, when we discharge the patient goes on the oral antibiotics. 3 questions done. Netaji Annepu, please, okay, we have got your mail ID. I'll just note it and I'll mail them on your mail ID. And any other questions? Okay, welcome. Sir, can we end it now?
Yeah, I think perfect. I really appreciate you, Uday.
Thank you, sir.
I like to see good surgeons giving good talks. Okay, there are surgeons who are not good but give good talks, but there are surgeons who are good but can't give good talks. But it is a good combination to have a good surgeon with a good talk. And I really appreciate you. God bless you.
Blessed. Thank you, sir. And Sriharsha, I think we can wind the session now.
Thank you, sir. Thank you, Jankiram, sir. I think you must have almost been sitting there since 3 hours.
Yes. That is Dr. Janakram sir's dedication.
Thank you, sir. Thank you for staying with us.
We create students not only to make them big, but because when we grow older, we need people to treat us. So a little selfishness also is involved in that. But then definitely we need all our students to be better than us. And I know Uday at one day will definitely be better than me or better than many,
so,
many
sir.
people in the world.
I just pray to God that
God bless
I
you,
become
man.
better
God
every
bless
day.
God bless you.
Yes, sir.
Thank you.
And Sriharsha, I think we have got a good kickstart for our web series for journal clubs.
I'm
So
really
we'll meet
happy, sir.
with the next session.
Maybe it's like a learning curve for us. We'll hope to improve much better in the further sessions. Thank you all.
Okay, thank you all. Thank you, sir. Good night. Thank you, sir.
Good
Once
night.
again.
Good night. Good night.
Bye.